Thanks to Jehan Marcoux, we have assembled some brilliant minds to cover the topic of the science of cannabis and COVID-19. Got a lot of material to cover, so let's jump right in. Take it away, Jehan.
All right, thank you so much. And as I'm sure your anandamide levels have peaked right before lunch, and they should be settling down, helping you to focus and not forget what we're about to talk about. So welcome to the science of cannabis and COVID-19. Over the past few months, there's been a rush to explore all potential treatments for COVID-19, and we must pursue promising treatments and scientific facts wherever it leads, which brings up the question of the position of cannabis and its products in this manner. And that leads to a disclaimer. We do not advocate for the use of any particular cannabis product to treat an infection or terminal illness without the advice of your licensed medical practitioner. Just to be clear, the FDA has not approved, conducted studies, or reviewed any clinical data submitted by a cannabis company on CBD for coronavirus or COVID-19. As with all things, off-label use of readily available therapeutics to limit the severity of this disease must be scrutinized. However, we will discuss some data that has been released ahead of peer review today, produced by researchers in Canada, and we're grateful to have them on the panel today. We're going to begin, before we dive into data and how it's created and what it means, we're going to begin with frontline updates. So we're going to hear from researchers in laboratories, health professionals on the front lines of education and access to cannabis. And our goal today is to stress what we don't know, to be clear when we are speculating versus discussing accepted facts, and provide you, the listeners, with a path forward. So let's start with updates from the cannabinoid laboratory, move on down the research and healthcare supply line, and after we get a nice baseline from these leaders in cannabinoid, cannabis, and endocannabinoid research and medicine, we'll move on to discussing the data, the methods used to generate that data, its implications, and what the remaining unknowns are. And to kick things off, we're going to start with a legendary pharmacologist from Temple University, Dr. Sarah Jane Ward, who has dozens of publications in this field, as well as tons of experience reviewing cannabinoid research grants and serves as a peer reviewer for journals. Dr. Sarah Jane Ward, thank you for being here. My question right off the bat for you is, what is it like being a cannabinoid researcher during this time? Has the DEA and FDA removed all barriers for your research during the pandemic, or is it even more difficult right now to generate some of the data that might be necessary?
Great. Thanks, Jehan, and thank you so much for inviting me to be on this panel. It's really exciting. So we locked down at Temple University most of our research laboratories in the middle of March. And so we had a lot of time as PIs of laboratories to hunker down in our living rooms and work on manuscripts and grant submissions. I'm currently funded by the National Institutes of Health to do cannabinoid research. My research focuses on chemotherapy-induced neuropathic pain and the potential for different cannabinoids to prevent or reverse neuropathic pain that's associated with chemotherapy use. And I will say that the funding didn't stop with the lockdown. So we were able to proceed as possible. So we went down to very, very low levels of staff in our laboratory. And as I mentioned, it gave me time to catch up on data we've collected, write manuscripts, submit grants. Temple University did allow essential research to continue, including anyone who was going to research COVID-19. And I can tell you that I did receive emails from several of my colleagues in infectious diseases and immunology asking me about the potential for cannabinoids, especially CBD, because of the anti-inflammatory effects that I always talk about in the hallways at work. So some of that work has already started at Temple in other folks' research laboratories. So research didn't come to a screeching halt, and I think for the most part allowed us to catch up on some things and also gave us some really new ideas and has brought forward a lot of new research possibilities for cannabinoids.
Thank you, Sarah. So just a follow-up question before I want to ask Dr. Leslie Apgar, warm up your windpipes. You're on deck. But Sarah Jane, viruses can vary greatly between the different types. You've studied HIV and CBD. You've been a part of some of those projects. So just real simple, putting this in a larger perspective, what is I know that there are many different types of viruses, retroviruses and those that aren't, but what's your view on CBD and viruses from the 10,000 foot, the 30,000 foot view, however high you want to be and share your perspective? What's your experience with CBD and this research?
Yeah, I think it's very exciting. So some of the work that I was allowed to be involved with was with a collaborator at Temple University who's interested in studying HIV in vitro. And so she was looking at viral load and the effect of exposing macrophages to CBD to see if that would affect HIV viral load. And she got some significant effects and has applied for a grant to explore that more. As a behavioral pharmacologist, I'm used to doing research in whole animals. And a lot of the virology and research with people that I talk about, a lot of it is still at the level of in vitro studies or in animal models that sometimes are a little bit more heavily criticized because they just model certain aspects of a virus. And so I think we're still in early stages as far as testing CBD with viruses. But knowing some of the mechanisms of action of CBD, I do think it's very promising, especially through the PPAR receptors, that CBD may have antiviral potential for sure.
Great. Thank you so much for the update from the front lines of laboratory research. Dr. Apgar, you're a stellar example of a medical professional in this field. Not only do you see patients, but you also work directly, with the dispensary, making sure patients have safe access. There's so many questions I want to ask you, but the first one is just how has your practice been affected by the COVID-19 pandemic? Are you doing telemedicine visits? How's that going? Oh, I need to unmute you with my magic unmuting.
How's that? Better? All right, cool. So Gina and I, who's my business partner in the dispensary, we weren't sure what COVID was going to do. We were one of the first states to shut down. And funny enough, our governor right out of the gate said that we were an essential business. So that put us into a very interesting perspective. And I had to flex my physician muscles a little bit. And as the medical director say, actually, this is a pandemic and we actually have to change went to curbside. And I got a lot of pushback for that because it's such a collaborative experience when patients come into the dispensary and they want to talk about all the different terpenes and they want to have a conversation with you. And we had to really change our ways because when you come into a dispensary, it's not just a quick and easy thing. You have to make sure that you are certified and that you haven't gone over your limit and that we have what you want in stock. So that was a problem, but one that we solved pretty quickly. And now we're so efficient at curbside, we never want to go back. So we certainly saw an increase in volume. And when queried, the patients would say, well, I'm anxious, or I have PTSD, or this COVID has just got me going crazy. Please help me. So we saw about an increase of 30 to 50% volume, and we're getting new patients every day.
Great. I know my volume appears to be a little low, so I hope this is a little bit better. But I really want to ask you, Dr. Apgar, what is your clinical experience, if you can share any, with patients who have tested positive for COVID-19 and are taking cannabinoids? Is there anything you can share?
There's two categories. There's the asymptomatic category of somebody who, oh, by the way, tested positive and had very mild symptoms. And then there's the patients who are at Hopkins who are intubated and in the COVID units. And it doesn't seem like there's so much of a happy medium there. It seems to be there's one or the other, at least in our experience as far as talking to the patients at the dispensary. But we have had a lot of interactions about how to use cannabis during a pandemic. And we used to think this virus was really a respiratory issue, but now we're finding that it's more of an inflammatory issue and it's a systemic effect on the body. So while patients were understandably concerned about vaping and smoking, if that's the only method that they can get the medicine into their body, so be it. But we certainly saw patients moving toward what I would consider safer as the edibles and the tinctures. And that's certainly the way we were counseling patients, especially initially with this respiratory virus that was initially, widespread. And also, I forgot to mention to you, happily, we were able to go telemedicine right out of the gate. The commission that is our governing body here in Maryland very quickly followed the AMA's recommendations to allow for telemedicine visits. And that was huge because now the patients can get certified via telemedicine. And then I was able to do my consultations, which I don't receive any kind of compensation for. It's just part of what we do that makes us separate and different than the other dispensaries. But it's so much more meaningful when you can look at a face, even if it's through a computer, than doing it in person. And it certainly makes everybody safer. You're muted.
Thank you so much for that
There you go.
update. I hope I fixed the sound problem now. So we're going to move on. We're definitely going to come back for follow-up questions for all of our panelists. But I want to move to Dr. Jordan Tischler. You're the president of the Association of Cannabis Specialists. What are the concerns of cannabis healthcare practitioners right now? You have members who might classify themselves as cannabis specialists or endocannabinologists or cannabis medicine specialists. What are clinicians saying to each other right now about COVID-19 and cannabinoids? Can you share some of those discussions or what's going on?
Yeah, I mean, I think that the discussions amongst the cannabis specialists are fairly similar to what you'd expect. I mean, everybody's talking about, things that Dr. Apgar mentioned, like being able to move into telemedicine. Speaking just from my own experience, my own clinic, it's been remarkably seamless and in some ways illustrates the ways in which we may find that there are some silver linings here, and that the reconceptualization of the delivery of healthcare or high school or various aspects of our community and our society under these circumstances gives us a chance to kind of reevaluate whether we were doing it the best way just because that was the way we were doing it. And there is something that's very nice about being in the office with somebody together, but the office is a very professional and somewhat sterile environment, and doing this by telemedicine is actually a little bit more like making a house call. And so I have gotten the chance to really see people in their environment. In fact, one of my favorite moments was I was talking to a young woman who had unfortunately advanced breast cancer, and her 5-year-old crawled up onto her lap while we were talking and said, "Mommy, I need a snuggle." So this was wonderful. I think that, the dispensaries around here have really done a very nice job of moving to either delivery or curbside, as Dr. Apgar mentioned, and that's really been good for helping our patients feel safe in getting their medicine. And then there's been, as you kind of mentioned, a lot of discussion about inhalation versus other forms of delivery. Lots of my patients have come around to ask me what I think. And, in a nutshell, I think like everything in medicine, it comes down to a risk-benefit analysis. If you're using cannabis for no particular reason, then there's a high risk. Whereas if you're a patient and you need this, and this is the best way of taking medicine, then that the balance is on the side of treatment and not so much on the risk side. So I think that, that kind of thoughtful discussion needs to happen more, and it's what we're seeing a lot of in the ACS at this point. Jehan, you're muted still.
All right, thank you, Jordan. We're going to go to Monica Tang, who is educating medical professionals everywhere. Monica, what are you focusing on right now? What's it like doing medical education for the last few months? I'm sure the standard intro to the endocannabinoid system might be getting a little dry for healthcare professionals when they're looking for information to apply and reducing risk for patients. So give us a little vignette about what's it like doing medical education and educating health professionals about cannabinoids during this time.
Absolutely. So I'm drawing from my experience as a doctor of pharmacy, and I had academic research experience on the endocannabinoid system and receptors through my time in pharmacy school. I was at Northeastern University, and it's a co-op school. So when I first learned about the endocannabinoid system, I was like, this is the tip of the iceberg. This is the beginning of change. We can usher in an era of evidence-based education, and we can train healthcare providers because they are the most on the fence, skeptical providers because they weren't taught conventional endocannabinoid science through a didactic curriculum from medical school, pharmacy school, nursing school. It's an opportunity to retrain everyone who is a licensed medical professional. So I've taken that experience because I'm based in downtown Jersey City, and in New Jersey, the medical cannabis program is expanding rapidly. There's a lot of barriers that have been removed so that patients are enrolling and they get access to whole bud or flower, whereas in New York State, there's a lot of barriers, and that each state is different. Each state's medical program has benefits and has drawbacks. But with New York State, they aren't technically allowed to have smokable form. And I've been training in New York and New Jersey, all the licensed healthcare providers who are looking to get the education on the background of the endocannabinoid science, but also tailoring it to specialties. So if I were to train an HIV/AIDS specialist, it would be different than how I would train, or it'd be unique and distinctly different from how I would train a substance use disorder specialist or addictionologist, because it's about meeting them where they are in terms of their reservations and their concerns, with the understanding that it is a Schedule I drug, that we have limited research, but where we can all agree on educating ourselves, educating each other, and counseling patients is harm reduction. We can talk about the pharmacokinetics and the pharmacodynamics of endogenous cannabinoids, of plant-based phytocannabinoids, how those will affect the homeostasis of the endocannabinoid system, and then how to counsel their patients on a start low, go slow dosing strategy, the risks and benefits of each delivery method, but then also how to monitor for potential drug-drug interactions if they're going to be taking something by mouth. That's a real risk and a real concern for providers, where for HIV/AIDS patients, if they're taking these antiretroviral therapies, they want to know what's going to happen if I'm initiating my patient on medical cannabis. If a patient does have a past history of addiction and substance use disorder, that is a qualifying condition for the medical cannabis program in New York and New Jersey and other states. But then also they're concerned about smoking and what benefits there are to other alternative methods. So going through it and having them understand basic pharmacology and how to personalize that patient counseling is something that I've been really focusing on lately.
Great. Thank you. You know, you mentioned something that's of a big interest of mine, which is drug-drug interactions. And so before we break into the discussion with Olga and Igor Kovalchuk, you guys are on deck. Monica, what are some of the potential drug-drug interactions of cannabinoids related to COVID-related therapies? High-dose corticosteroids, interleukin-6 receptor antagonists, hydroxychloroquine, if you want to touch that one, or other COVID-related therapies. And feel free to discuss this, you know, from the co-management of patients who are using a medical cannabis or CBD-rich product and potentially being also exposed to COVID therapies.
Yeah, so if a patient is going to be initiated on medical cannabis, the first thing I've done in dispensary trainings, where I've been guiding hopeful like dispensary applicants or active dispensary operators through how to interact with the patient when they step foot, or now that they're on telemedicine, if they're doing like the virtual and phone call counseling, telling them the importance of step one, a medication reconciliation. And that's a step that pharmacists use in standard practice and other healthcare providers, where it's a form of drug utilization review where you combine a whole list. You take a list and it's tailored again, specific to the individual patient. And you have to write down all the prescription medications you're taking by mouth or anything that is injected, sublingual. All these will have different systemic absorption and different risks with drug-drug interactions. And anything new, anything long-term, any over-the-counters, herbals, supplements, nutrients, anything that could possibly interact with their liver enzymes has to be accounted for. And then they need that to be checked regularly and frequently. And I'm also telling that on the other end to the healthcare providers who are doing medical trainings, where some are like, oh, I don't even care if they're on cannabis. It's a don't ask, don't tell policy, but risks are associated with it. So when we're talking about, I'm trying to think of which one I would want to pick. I guess any drug, really. So like drugs that are taken by mouth, patients need to understand that there are the risks that are associated with them, such as like a black box warning. And if a black box warning is talking about the risk for arrhythmias or any other adverse cardiac events that are associated with that medication and that are established at baseline, that is a rationale for, based on the symptoms that they're trying to address and trying to manage, a patient wouldn't really want to start with a high dose potent THC cultivar or chemotype, because we need to have that start low, go slow conversation around gradual dose titration to avoid the risk of tachycardic events or rapid heart rate, and that could really also worsen anxiety. It depends on the product-specific consideration and patient-specific considerations. If the patient is treatment experienced versus if they're treatment naive, it all factors into the considerations around the counseling of drug-drug interactions.
Wow, thank you, Monica. That's a great overview. So Olga and Igor Kovalchuk, you guys are sharing a microphone and a laptop, so I'm gonna let you choose who responds to this. So I have two questions I really want to ask. So the first one has to do with the preprint. You know, the peer review process is crucial for validating research studies. Your study was recently published as a preprint on cannabis extracts and COVID-19. Now, preprints, they can be a very helpful way of disseminating information, especially during emergencies, such as the COVID-19 crisis. It can also help authors to improve papers before publication or potentially raise money to complete a study. So first off, have you received any critiques on your study, and will it help you prepare your paper before you submit it for peer review publication?
Right. Well, first of all, we are poor Canadian scientists, so we only have one computer. Just kidding. So you're absolutely right. So that's our first experience with preprints. Each of us has well over 150, close to 200 peer-reviewed publications. We normally don't do this, but because of the urgency and because of the importance of the topic and the desire basically to let people know of the possibilities, we have published preprints, right? So meanwhile, we have submitted those two papers to peer-reviewed journals. We already received some reviews from one of them, right? So right now we're working on basically resubmission. And you're right, so we received many comments, good and bad, right? So some people are modest, some are nasty, right? So that's okay if everyone who published know that reviewers typically are nasty, right? So because that's their job, it's their competition, you are competition, right? So, and especially if you put something out that is so out of this world. I remember my early days as epigeneticist, when I would present and give a talk in early 2000, 2003, 2004, and people would, from the audience, shout saying, "Yola Marquez, you shouldn't be here, blah, blah, blah," right? So I'm still here, right? So, and same about COVID and cannabinoids or cannabis. Absolutely, some of the good reviews that we received, that the entire, I've seen university, I believe in UK, that they undertook a very careful approach and scrutinized every single experiment, and that's wonderful, and of course it helps us. So we have meanwhile done additional experiments, reconsidered how we phrased the experiments, and anyone who tried to publish know that you go through 3, 4, sometimes 10 journals. It sometimes takes 3, 4 years to publish. So we did not expect this to be published immediately, but this knowledge had to be given to people immediately.
And if I could add to it, the reason, again, it was our first two experiences with preprints. My colleague previously, we had another paper and he said, "Well, do you want to put it on preprints?" I was like, no, not necessarily. It's not like a rush. But this time we thought, well, for the reasons you have listed, because it is a health emergency and we all are in an unknown world, we don't know what works. Everybody tries to contribute. And we thought, well, we found this. This may be interesting. Maybe somebody else will read it, send up their views to us, continue doing maybe what they are doing, because there's so many people in this field and they may think, oh, I haven't thought about it. Maybe I'd also do it, you know? And it was really valuable to get some of the feedback.
Great. One example, I've been contacted probably over a dozen of various medical practitioners. One doctor said that they are in the front line working with patients, and as soon as they've seen the publication, they gave 5 patients CBD, CBG drops because that's all they could get. And all 5 recovered, and I received statements from 4 patients out of 5 saying and being grateful how it helped them.
We'll save that case report for your next publication. But to get back to the preprint, there's a lot of media hype around these stories. A lot of people are saying all sorts of things. Could you just, for the audience who maybe isn't familiar with scientific data, discuss the promising results from your study and the limitations? Because I think sometimes this aspect, this yin and yang approach to discussing science is often missing in the general discourse in the media. So what were your promising results and their limitations?
Absolutely.
I'll start from breeding because that's an important part. So we didn't take any generic cannabis. So we have started with close to 1,500 hybrids that were created by crosses, very distant crosses between different cultivars. So, people call them strains, right? And we have selected about 400, made full flower extracts, so full botanical extracts out of it, and profiled them initially for various breast cancer cell lines. So we have identified about 4 dozens of them that work very well, so 10%, right? And out of these, we assume that one of the reasons it worked on cannabis, on cancer is inflammation. So we took this 48 and did all the anti-inflammatory panel and identified about 2 dozens that worked well. Dozens, and basically use them for other studies, including COVID, and Olga will comment on that.
So yes, actually, again, a little step back. We were working on cannabis, as Igor mentioned, way before COVID started. So COVID just started and, it mixed up everybody's plans and messed up everything, but also essentially brought some opportunities for new collaborations and new research, as we all now know, right? So because we were focusing, as Igor mentioned, on anti-inflammatory, we were developing several strains. Actually, in the paper, I call them lines, and, I guess we confused some people. Well, actually, you should call them cultivars or strains. So.
Not strains. Not strains.
Okay, never
strains.
So you see,
yes. Yeah, there are strains of bacteria and strains in your elbow. There are varieties of cannabis.
Yeah. Anyways, so the cultivars that were developed, one of the interesting focus areas was rheumatoid arthritis. And we actually were really hopeful to even start a clinical trial. We already had a protocol being written, and we're really well advanced. The original plan was to have started it in Q2 of 2020, which is now, but nothing has started. But we already had a whole bunch of data. And what we were doing also in parallel, we were looking at the effects of extracts on inflammation in the oral tissues, on inflammation in the lung epithelial tissues, on inflammation in intestinal tissues. And so essentially when COVID hit, we were sitting on a huge pile of data, which was absolutely unbiased. And this is what we did. When it happened, I was just discussing with my colleagues, and they were like, why don't we just look at whether or not there is any effect on some of the key gateway genes by these extracts? So, and we looked, and this is how we identified some of the extracts that were affecting ACE2 receptor as well as TMPRSS protease. And we thought this was really, really important. And we have done as much as we could, because as you all know, we are under the lockdown. University is still in the process of opening only. You have to fill out this much of paperwork to get a couple of people in. Only they're working on COVID. And that's kind of, you know, we were able to do some of the things. And this is how, again, we have done it. And this is an initial step. And of course, with every paper, we're now anxiously waiting for more comments, as well as, so now we're addressing some of the reviewers' suggestions on the article that we have received, and also actually introducing some of the comments that we received again from the public. Because we thought, you know, this is a great opportunity and great idea to also, actually in my letter back to the journal, I was like, I'd also thank those, you know, public contributors who suggested doing this, and we also added that.
So basically, if I make point of criticisms quickly, where low number of repetitions.
Yes.
Well, it's obvious because we just have no capacity to repeat that. So we'll do that as soon as we are back to work. Yes, it's a valid criticism, right? Then second comment is they are hiding cannabinoids and terpenoids contained. We've done all this agnostically. Frankly, as a medical practitioner, why do you care what terpenoid profile it is? You care whether it works. So we first establish what cultivars work, and then we'll try to understand why they do that. So for most of the cultivars that we use there, we do not know terpenoids profile. So we have sent some for analysis right now.
And so, in a sense, you are blinded to what you're putting in the test tubes, as it were. You don't know if it's a high CBD or high THC. It's, you know, it's just a number, and you find out later. And that, you know, I think that actually might preserve some of the integrity. And you know, please, you know, so please continue for another minute. But I want to ask some of our panelists about your paper.
Yeah. So what I would also suggest that, yes, and the other very important thing is, as Igor mentioned, that we were totally unbiased by it. We just chose the ones that work, and then we said, okay, is there any commonality between them? But in the meantime, what we've also done, we were able to, using very limited resources, because right now grant funding is this, literally, like, everything is canceled. Look, go and see our website, all's postponed. So, but we were able to actually conduct experiments and reproduce the data, which is really extremely important. We're adding it to the response to reviewers. It's actually reproducible in tissue culture as well as in the tissues as well. Fingers crossed. We have done several experiments and works perfectly.
Thank you. Thank you. As a US-based cannabis researcher, I have extract envy. Like, I'm going to go to Sarah Jane Ward on this question. Dr. Sarah, you've been a cannabis and cannabinoid researcher for a long time. As a US-based researcher, could you even replicate, and I don't mean technically, but is there even a pathway for you to replicate what Dr. Kovalchuk and Dr. Kovalchuk have done? Could you grow cannabis at Temple and then extract it? Like, how much trouble would you get in for that?
Lots. Yeah, so that, you know, that's a big challenge. And I think what we need is to approach it from both ends. So, you know, there are strengths in just looking at what CBD does, just looking at what THC does, what does beta-caryophyllene do, and I can do that. But it's also very important because what most people are using is whole plant with hundreds of different chemicals, many of which may be very important for efficacy and safety. So the current challenge in the United States is that clinically, people can do clinical trials on one strain of cannabis that the NIH grows on a farm in Mississippi, and it has a certain amount of THC and a very low amount of CBD. So for those of us who want to know more about CBD and high CBD, low THC ratios, there's not that product available. From an animal researcher perspective, you know, all I can do is have my Schedule I DEA license and order CBD, order THC, test those drugs in isolation. The most I've done so far is combine two to try to start to look at, you know, different important ratios, and I'm getting into more of the minor cannabinoids and terpenes. And so, you know, and we have these wonderful medical dispensaries, and I talk to the people who operate them, and they would love for me to test them, right? We want to know, what do your products do? And we can't, because I do research at a federally funded institution. My research is funded by the NIH. And the cannabis down the road from me in downtown Pennsylvania is federally illegal. So that is a major challenge. I do tell people all the time, because I'm aware of the research that is happening in Canada. Sometimes when I can't answer a question, I say, well, maybe in 1 to 5 years, we'll be able to answer some of these questions, primarily because some of the science is moving forward so well in Canada. So I'm really excited and envious of the Canadian researchers. And, at the end of the day, we all share the information. So we're gonna learn a lot, and things are gonna move forward really quickly.
Excellent, thank you. This question, is for all panelists, but I'm gonna start with you, Jordan. Based on the conversation so far, what are some unanswered questions, or one unanswered question you have right now that if you could wave a magic wand, you'd want answered?
Oh my goodness, that's not a fair question. It's too darn broad. But I mean, should we say around COVID or just cannabis in general? Because
I'd say around our pool of data with COVID and cannabis and comorbidities and things like that. I can ask a different question if you prefer, more specific.
Well, I think, the biggest problem for us at the moment, and I think that the Kovalchuks just really elucidated this well, is that, the pandemic is a huge problem, and it's very acute, right? And everything has ground to a halt. And so we're struggling to find things that might help. And we've now got some evidence that certain portions of cannabis could be helpful. But one of the biggest problems we have, not specifically with relation to the COVID stuff, but kind of generally, when we start looking at cannabinoid research, is that it is done in cell culture or in mice, right? And, virtual show of hands, how many of us are mice? The answer is none. And it turns out, I actually had to look this up some years ago, that 92% of medications that work for mice don't work for people. That's pretty lousy odds, right? So, the fact that we can say, okay, CBD looks like it works in cell culture, if our federal government were really behind this, we would be fast tracking the human experiments, right? And we could be doing dose titration experiments so that we could figure out, does it work? How much do we need, and how do we provide it? And we're not there. We're not gonna be there soon.
Okay, gotcha. Thank you. So Dr. Apgar, let's see, you're a leader in cannabis and women's health in the United States, and probably, around the world. You're very well known for your passion in this area. As with most medications that are prescribed to women, some of them have only been tested in men by the FDA. This is a big problem with medications and treatments only being tested in certain populations before going to market and prescribed to everyone. Are there considerations for women's health during this time with cannabis and COVID rates that maybe people aren't acknowledging or aren't addressing? Do you have some concerns in this area?
I love the question, and thank you, because men and women are not the same creature, as it turns out. And all of these medications that we so willfully prescribe have really never been tested on women, and it's a huge pet peeve of mine. As it turns out, we don't respond to cannabis in the same way either. And that is by our observations and from what all of our patients were telling us right out of the gate. And it also turns out that males and females are not attracted to the same kind of cannabis. So that is something that Gina and I did right out of the gate, as we said, hey, listen, there's nothing for women here. Why are women not even being part of this discussion? Women are the entry point for the family for healthcare. And so why is nobody addressing this? So we actually had to create our own line of cannabis products for women, specifically targeting women. And that's really fun to do with no research, right? So basically what I did is, and what we all did, is we watched, and we had the patients come back and give us feedback right out of the gate, and just kept a lot of notes and paid attention. And women don't well, a lot of our women don't want to feel impaired. They are busy, they're moms, they're working, they're trying to run the household. And so they really wanted higher CBD products. And they also like certain terpene profiles that we found. So the reason, I mean, it's not science, guys. It's us paying attention and then trying to do in a very limited way with no ability to do research to respond to what the market was demanding. But most of my females will say, please give me something that is not going to give me the munchies. And it turns out from some of the data that I've been looking at that really THC does affect men and women different in that capacity. And I would love to know what's happening with the terpenes and the terpenoids. Why is it reacting that way? How is the estrogen level in our bodies affecting our own endogenous cannabinoids? And how is that affecting the phytocannabinoids we bring in? How is it different when we're talking about exposure to COVID? How are men and women handling it differently? There's some data coming out that says there's a definite difference there. So the way we're handling it in Maryland is we're basically trying to boost everybody's immunity and just try and talk about globally, you know, how can you be the best that you are, and how can we, because, you know, COVID's here, COVID's not going anywhere, sadly. So how can we do the best that we can with what we have? And that's how we're approaching it.
Oh, thank you. Thank you. We're starting to get some questions in from the audience. There's just a couple. I have a couple more COVID focused questions before we go into some of the audience questions for the last half hour. You know, this is a question, I guess, for anyone on the panel who wants to follow up from you, Leslie, or we can go on another question, but to follow up to that, is there a role, do you think, for high THC in assisting the immune response in patient at risk for cytokine storms during infection with COVID-19? Is that maybe gender specific or person specific? Do you have any comments on that?
Jehan, can I just add something?
Yeah.
To follow up with Leslie on males versus females. So one of the more interesting stories that's emerged recently in pain research, again in mice, is that there is a differential involvement of different cells of the immune system in the development of chronic pain in male and female mice. And a lot of it revolves around T cells. And I could, you know, I'd love to talk with everybody all day long about T cells and cannabinoids, but T cells play a differential role in neuropathic pain in males versus females. And I was just looking at a recent article this morning looking at the effects of CBD in a rat model of neuropathic pain, and CBD differentially affected pathogenic T cells in male rats versus female rats. So I think a lot of times when we think about sex differences, which is really important, we think about, are the side effects going to be different in men versus women, or is it going to relieve pain differently? But even, you know, going down to the molecular level of a T cell response can be differentially affected, and talking about COVID and infection and CBD, that's a really important topic to consider.
Okay. And if you don't like, thank you, Sarah. That was a wonderful addition. And anyone else have any comments? You know,
I'll make a brief comment. I couldn't agree more with both Leslie and Sarah. And actually, for the past 10 years, I've held a CHR chair in gender health. And specifically, actually, CHR was very, very strongly behind introduction of both males and females into clinical research as well as biomedical research, because we have learned the hard way, as Leslie mentioned, that how many clinical trials have failed because they haven't included males and females. And from some initial studies we have done in our laboratory, actually in collaboration with our neuroscience colleagues, we do see, you know, I wouldn't want to comment more, but there definitely are sex differences, and it really has to be very carefully looked at. It's really very, very important.
It's also very essential to see there is a difference between males and females in the expression of we did about 80 genes that are related to endocannabinoid system.
Yeah.
And first of all, we start with a different expression. When we age differently in our endocannabinoid system. And women are more vulnerable actually to addiction in endocannabinoid system. They have higher expression of the receptors. They have more polymorphism in these receptors. And what we found also, there is a almost perfect negative correlation between the level of CB1 receptor and ACE2 receptor on the surface. And this correlation is more prominent in women. This is just a data bioinformatics that anyone can look at. And maybe that's the reason why male are more vulnerable in COVID.
Fascinating information. Thank you. It's that brings up some other questions that I have, and anyone's welcome to chime in here, but I have not seen any data publicly available that shows a decrease in core comorbidities associated with cannabis use or hemp use, what have you, in COVID-19. So, I personally don't think there's great evidence to suggest prevention or treatment of COVID from just cannabis alone. There's too many other factors. However, there might be a real opportunity, a real true potential to help with recovery, maybe help with secondary infections and illnesses related to COVID. And I'm going to open this up to the panel. Who has some thoughts on cannabis and secondary complications, secondary infections, and the recovery associated, with the recovery of COVID-19 syndrome, the post-COVID syndrome? I could see potential for PTSD, anxiety, as well as physiological recovery. Jordan, you look ready to go.
Yeah, well, I think that you kind of nailed a bunch of them, right? I mean, we're going to see or are seeing sort of a whole constellation of issues. So anxiety for people who are not actually infected with COVID or maybe have just kind of recovered. And then we have the people who, as Dr. Apgar mentioned, ended up in the ICU, right? And they're going to have a whole bunch of PTSD. So there's a whole gamut of mental health effects. And this, just being quarantined is a huge issue, right? So in my practice, I've seen an explosion of people coming with these sorts of anxiety-based issues. And then, as you pointed out, we're seeing actual post-infectious complications. And one of the huge ones is neuropathic complications. And that's an area where cannabinoids of various types are known to be effective. And certainly people with neuropathic pain respond to small doses of THC very well. And there may be some role, as we're starting to see, for other cannabinoids like CBD. And we haven't talked at all about THCA today, but that's a cannabinoid that I think is distinctly under scrutinized at the moment. Again, partially because the feds block that because it can be so easily converted into THC. But frankly, in several theories that I've seen, particularly in treating inflammatory bowel disease, which is an autoimmune disease, the THCA is actually significantly more effective and more potent than CBD. So in my clinic, I have a large group of people with various autoimmune illnesses. Small doses of THCA, either with THC to control pain or without it, just to address the underlying pathology, have been extraordinarily effective. And we've had people either come to complete remission with conventional medications or without conventional medications. So I think we're going to see a whole bunch of emerging uses for various cannabinoids, after a while.
Excellent. Yeah, we just got a relevant question, very, very specific question from the audience. Ron Shapiro writes in with a question about any work by the panel seeing anything specific to the ACE2 receptor affinity, even pre-COVID. So to translate this to researchers and doctors, can we connect the ACE2 receptor, which is a target for prevention and treatment of COVID, to the endocannabinoid system right now? I'm thinking, Jordan says no, not yet. This has been a weird panel for me because I'm so used to cannabis researchers talking about what they don't know, as opposed to what we do know. It's refreshing. Um,
I'm in with
but-
the pharmacist perspective about the
yes,
ACE2
please.
receptor. So a clinical pearl that we always are ingrained in our systems in like training and education for pharmacists is with the blood pressure medication and how the ACE inhibitors are acting specifically at the ACE2 receptors. And a common side effect that isn't life-threatening or an issue for patients is a dry cough. And that dry cough could be something, while commonly encountered, and again, in no way is it a real danger to the patient, but ACE inhibitors are written into a lot of clinical guidelines as like first line, second line therapeutic options. For this new COVID-19 era that we're navigating, it's a huge counseling point that could be missed for patients, especially if they're medical cannabis patients. So when we're talking about, as Dr. Tischler had said earlier, weighing the risks and the benefits, the potential pros and cons of each individual route of administration or delivery method, if a patient's going to be initiated on an ACE inhibitor and you screen for that in the medication reconciliation, that's something that you want to bring to their attention and also possibly want them to screen for, so that maybe they do want to go with a sublingual tincture. Maybe they do want to go for, if it's local pain, that can be addressed with a topical, talking about a cream, lotion, ointment, and the benefit of those effects. Because if you are to experience the dry cough and you're currently using inhalation, whether vaping or smoking, that could be the scapegoat, and there could be a I guess, not diagnosis, but an affiliation that will stigmatize the smoking or inhalation more, where it's like, this is harmful, this is like causing an issue, so I'm not going to use that. It's like benefits versus risks. And while we're talking about inhalation as not the primary optimal route, it could be one if the patient is healthy, if they have healthy lung function, if they're not on certain medications that could lead to this dry cough issue. So something to consider is that it's individual to the patient on what benefits they could really derive from certain delivery methods.
Can I jump in here just to make a point stemming from what Monica just so eloquently said? And that is, you know, we also have sort of lumped vaporization altogether. And so, you know, I'm going to pull out my little handy props here because I'm sitting at my desk. You know, we've got the little oil pens, which I generally try to avoid calling vaporizers, but commonly they are. And the problem with these things is they're not actually vaporizing, they're combusting the oil in there. So even if we don't have a problem like we saw last summer where people are putting things in there that shouldn't be there, we also still have sort of fundamental technological problem that we're burning this stuff and creating carcinogens, et cetera, from that. Whereas if we're using a flower-based vaporizer that is microprocessor controlled, we can be reasonably assured that if the temperature is set, which it should be at 350, then we're getting cannabinoids only, you know, and then we're not getting benzene and acrolein and methacrolein and all the other horrible things that we want to avoid. So, you know, again, having that discussion with the individual patient and weighing those risks and benefits with them so that they understand the decisions that they're making, and that, you know, this is kind of in the good column and this is in the not so good column. Those kinds of things are really relevant even more now that we're worrying about lung function.
Excellent points. Thank you. You know, there is one other thing, another elephant in the room regarding cannabis and COVID that I feel obliged to ask the panel about. And I'd love to get some of your thoughts from any panelist you know, about the many false claims that have been made online that medical cannabis, I mean, I heard it on a podcast 2 weeks ago. Cannabis can treat or prevent COVID-19. You know, how can we safely guide patients during this pandemic? You know, Dr. Apgar, you work right on the front lines of safe access. I'm sure you've heard some of these false claims. Any of our panelists want to chime in with maybe discussing some of the false claims they've noticed online?
You know, I will probably pitch in here because when we put the preprints out, of course, as you mentioned, there was lots of interest. And oftentimes people will call, and every time we talk to anybody, I would say, number one, this is a preprint. We are still working on it. This is cell culture and 3D tissue experiment. And the next thing, which we'll always emphasize, both of us, we absolutely need a clinical trial to bring it into the evidence-based realm. We need a randomized control trial to see whether or not what we see in the, which is promising, withstands the scrutiny of a bona fide RCT, right? For which we're trying to raise money. But oftentimes people hear what they want to hear. You know, and people know that people believe that cannabis is a new magic drug that was prohibited for many years. It is, you know, and therefore it works. They hear high CBD, they hear cannabis, and they just start making conclusions. And oftentimes they say, oh, is smoking cannabis going to cure COVID? No, we never said that. Please. But, you know, again, people hear what they want to hear, and we try to explain as good as we can, but oftentimes it becomes one person interpreting what the second person said to the third person, and it becomes, and the story gets a life of its own.
We have to do what we're doing now, right? So we have to educate people and respond to, you know, if we see some false claims, we have to, I don't know, not necessarily act on it, but try to correct it. So as we're doing now, so, well, whatever false claim is, we have to explain, well, no, actually this is like that. And that's the only way with how we can do that.
But the true thing is, hopefully with more events, with more education, with more outreach events like this, we could actually all start getting our regulations more straightforward so that more research and more clinical trials are done. Because that's the only thing that's lacking, research and clinical trials. And then we will not have any false claims.
Excellent.
Yeah.
And
Can I add that I
Monica?
talk about like the research and education and myth busting and how we are in the dawn of a renaissance for advocating for more research and for legalization and ending the war on drugs. A lot on the to-do list, definitely. But with addressing common myths and misconceptions, it's also really taking that opportunity to provide re-education, because we all have research, science, medical backgrounds. But for a lay individual, it's walking back to how, yes, RCTs are the gold standard, but also the study that they're citing for curative properties or anything positive, we have to evaluate it with a critical eye for statistical significance, internal validity, generalizability, and breaking that down into simple language. So it's, what was the inclusion criteria? What was the sample size? What were the characteristics of those participants in the study that were evaluated? And how does this apply to you in a real life scenario in terms of patient-specific considerations, also product considerations, product-specific considerations, because of the heterogeneity or the vast diversity, the infinite variety of cannabis products and like where they're being sourced. Maybe you shouldn't be using something that doesn't have a certificate of authenticity or certificate of analysis or hasn't been sourced from like a licensed facility or a reliable person that you know is not going to have it, is going to have a product that's contaminated with mold, mildew, harmful toxins, other chemicals, things that are specific to the plant that could be when they're inappropriately cultivated, packaged, if they're adulterated in any way. All these risks are very real risks. So while we're waiting on the research and the data and the science, and we're trying to make up for that lag in the knowledge gap, we can implement, again, harm reduction strategies where let's be realistic about the science. Let's be realistic about the facts that we know and how you can implement that in a real way to be safe, to optimize efficacy of the product that you're using and quality of life for symptom control.
Thank you, Monica. Dr. Apgar, you have
Yeah, I
comment?
was just going to say, spying on my lectures, or else I've been spying on hers, because she is completely echoing the same thing that I constantly have to do, which is to level set the patient and spend so much time trying to educate them that the CBD that they got at the gas station is not in fact the same quality as the CBD that we are providing, and you know how important a certificate of analysis is. It's so important, the education piece of it. It's unbelievable what patients will read on the Facebook or internet and think is an actual study and come in and want to have that strain, and we have to have that whole conversation. And that's really frustrating, because a strain is not a strain, it's not a strain. And also refer to them as chemovars, and I try and educate, and I try and educate about what a sativa is or isn't, or an indica is or isn't, and how it is so ridiculously antiquated. So there's so much opportunity for education, and that's what I do. And it sounds like Monica's doing the same thing every day.
I'd like to jump in with a little comment too, which is something that's kind of been bothering me for a while. I mean, Monica had mentioned in passing sort of the agenda of things we need to accomplish. Particularly, she mentioned legalization. For many social justice reasons, I certainly support this idea. But one of the things that I've realized sort of through the School of Hard Knocks is that, well, here in Massachusetts, we've certainly seen this in large degree, that one of the unintended consequences of flat out legalization is that we're going to see less research done, unfortunately, and not more research done. Because if you think about the research that gets done on medications at this point through the pharmaceutical industry, whatever you think of the pharmaceutical industry, it's done because the FDA requires it to be done before these products can get to market. And they cost millions of dollars to do these studies. And if we then open the floodgates to say, you don't have to do this research, you can just put the product on the shelf, what self-respecting company is going to put $50 or $100 million behind something if they don't have to? So we need something that's more nuanced, that allows us to be able to, end the war on drugs without question, but do this in a way as a nation that's thoughtful enough that we can promote this research and promote patients getting what they need, and that sort of agenda, in addition to some of the social justice issues. In fact, I would argue that patient care is a social justice issue.
Excellent.
I just wanted to add, and that's exactly how I feel about hemp-derived CBD. So in some ways, I got excited when that happened, but it's like two of the worst things also come with that. One, a group of people will think, oh, see, this means that CBD is a wonder drug and I can go buy it from the gas station. Actually, three bad things. Two, the market is such that there's less of an impetus for companies to do solid research because a certain percentage of the population is already on board and doesn't need to see the research. And then I hear from the other side, it also, I think, delegitimizes it because other people see it, well, it can't be a real medicine if it's sold in the gas station. So I think there, a lot of challenges have come with the deregulation of hemp-derived CBD, starting with the fact that it's not regulated.
And Sarah, we have a question coming in too that is related to COVID, but since you've actually studied terpenes in the lab, I want to pose these two questions to you. Two separate attendees have asked about, is it a good idea to maybe, a two-part question, is it a good idea to go back and look at all the aromatic and terpene data about viruses and start choosing cannabis varieties based on that? And the other part of that is it worth it to study the terpenes by themselves and in conjunction with cannabinoids? As you said, in the US, we got to piecemeal this stuff, one compound at a time. It's just the way it is. So your thoughts and comments on.
Yeah, well, first, I want to thank you, Jehan, for teaching me about terpenes. I don't know if you remember your presentation in Cannabinoid Journal Club 12 years ago at Temple, but you're the reason I study beta-caryophyllene in the laboratory now.
Yes, I remember that. I brought fruit juices that had different terpenes found in cannabis, and I think there was a big miscommunication because nobody touched the juices when I said they
they were all full of weed, right?
I was like, I'm not touching this mango juice. It has myrcene. That's a cannabis drug. Please continue.
Yeah, so the grant that I'm currently working on now, it's actually funded through the National Institutes of Complementary Medicine. And so it's all phytocannabinoids and terpenes. So it's CBD, THCA, CBG, and beta-caryophyllene. And right now we're focusing a lot of the work with beta-caryophyllene. And one of the big questions, I do think, and maybe this is just my bias from the kind of research that I'm used to doing, I do think it's important on one end to start with the single entities. When I think about testing different chemovars to get a different profile and extrapolating from that, oh, because that chemovar is high in BCP or THCA, that means that that's what's driving it. At the same time, I think it's important to study those compounds in isolation. What is BCP capable of doing on its own? And one of the things that we see in the animal studies is that it takes really high concentrations in the animals to see effects. Again, this is a mouse. So what does that dose in the mouse mean to how much BCP in a person? But, I see a lot of people looking for products with certain terpene profiles. And, we barely understand dosing of CBD. Never mind the concentration of these different terpenes that may be in it. And I'm not saying I'm very excited about them. I want to know way more about them. But I think, things are going to happen on both ends, which is just the way it's going to be right now. But I think it's important to do the research with the isolates, determine dose response curves, what is the efficacy, what is the safety. And on my end, I'll do that in isolation and start combining them very slowly and strategically. And then on the other end, we can be looking at the different chemovars and then hopefully all meet in the middle and celebrate.
Awesome.
Sarah,
Jordan, did you have a comment? Because there is a question about something you said earlier.
okay,
You're ready.
I just wanted to say, is just on a clinical note, to what she's been talking about, I've had the opportunity to try clinically some, dual isolate, so THC CBD product, particularly in pain patients. And the interesting thing is, they work, but they don't work as well as ordinary cannabis. So there's clearly something missing, and it's just going to be more complex than what we're looking at right now. And I think just my personal biased opinion is that the beta-caryophyllene is going to be one of those key ingredients specifically around pain control. Anyway, that was my little aside.
Okay. So I'm going to ask one or two more questions, and then we're going to end this panel. I'm just going to go to each of you with your kind of final thoughts, take-home message. So Jordan, yeah, for once, it wasn't me talking about vape pens on a webinar. So, we have a question from an attendee is, what evidence do you have that that oil pens combust oil? So like just the 30-second elevator pitch on how do we know? I mean, I know, I have my answer, but what's your answer?
Well, my answer is that there are a series of studies that look at how these things work and measure the output of the device, and we can measure how it's behaving, and we can measure what those chemicals that come out of them are. And we can also look at the temperature of those devices and compare it to the temperature at which we know that certain compounds, like some of the terpenes, combust into other products, that we then know something about what those products do. And two of the big ones are acrolein and methacrolein, which are particularly potent and nasty carcinogens, the kind of thing that we like to avoid. I hope that helps the answer.
Thank you. Thank you. So for kind of closing thoughts here, we have about 6 minutes left. So let's try that. 6 minutes, 6 panelists. We should be able to do this. I'm going to go first to Igor and Olga Kovalchuk for your closing thoughts for the panel. I know that attendees are interested in how cannabis researchers and other people can support your work in other areas of cannabis chemistry you're interested in. But feel free to use this time to talk about anything for your closing statement. But I know people are interested in how they can support your work and improve it.
Right, so yeah, so then I'll answer this question first. So basically we have probably at least 6 or 7 are scientists and companies reached out to us and saying, please study our product, right? So the best, recently we've been sent 25 different extracts by the company who wanted to see whether they have the same effect. We're open for collaboration. So if, unfortunately, you have to have a license to work with it, right? So only scientists who can help us are scientists with a license. And only in Canada, because we cannot send the product across the border without major hurdle. But yes, so if you have something interesting, if you want to study something, we are open to it. We come to this completely agnostically. We don't care what's a profile. If you rumorously think that a specific line is interesting and helped people, would be happy to look at it, right? So, and study it.
And one thing I can add to it, that actually, yes, the so-called reconstruction experiments would be the ones that what Sarah mentioned will all meet in the middle. People who study individual isolates, people who study the extracts and do reconstitution experiments. Yeah. When you fractionate and then you try to add them back together and see when is your effect coming back in. And that's being actually done right now in the lab, fingers crossed. And we know that for cancer, we know that CBD isolate versus the same amount of CBD in the extract, we're talking 1 to 10 difference in efficacy. That's, we're about to publish that. And we are really happy that this type of panels occur where we can discuss and bring.
Thank you.
Piece of information, for example, we studied separately the effect of THC on different cancers, and we found 2 cancers. On one it works perfectly, on another it does not work at all. Then we took a bunch of high THC extracts, and we found several that work perfectly on the cancer where THC alone does nothing.
Gotcha. Well, thank you so much for being so open and sharing and discussing your results. We really appreciate it. Moving on down the line for closing statements, I guess we could go alphabetically with Dr. Leslie Apgar. Final thoughts for the panel?
Yeah, I'm just going to make a plea that I would really love to have CBD accessible, that there's just none. And when states go from a medical state to a recreational state, there goes the CBD. And here I am in Maryland in a medical state and I cannot get CBD. And it's just atrocious because for my specific products, Placebo, that we're making, it's majority CBD with a little bit of THC, different ratios, different terpenes, and the patients are crying. I mean, they just are. I mean, today I was at the dispensary. It was a crazy day, and everybody was like, "Where's your CBD flower? Where's your CBD flower? Give me your highest CBD vape. What do you have in CBD?" And the answer is like nothing. And it's the market is trying to grow the highest THC flower because they think that that is what is necessary. And I constantly tell patients that's like going to the wine store and asking where the Everclear is. Like, can we not just have a nice Pinot Noir with a little soft note of THC? It's just disgusting. So my plea is to please make CBD the most important cannabinoid out there so I can have some for my patients. But I do appreciate the opportunity to be here with you very smart people. It was a fun afternoon.
Thank you, Leslie. That is a terrific point about CBD. While it might seem to be available in large amounts online, it is actually very difficult for people to get qualified sources of it. Fantastic point. Thank you. Moving on, Monica, you've been great as our resident pharmacist on this panel. What are your closing thoughts for our attendees?
Well, firstly, thank you, Susan, for having me speak on this panel among living legends. Also, thank you to my co-panelists. Great education, amazing points were made. And in closing, I would like to share my dream for the future with everyone in hopes that we can all be allies in achieving it for, again, the re-education of all communities, all audiences, starting with healthcare providers, starting with ancillary medical professionals, because even those who aren't the overseeing practitioner or the prescriber, they're all involved in different ways with patient care. I think we can all agree that it's important that everyone has education on the endocannabinoid system, on the safety and efficacy, real risks and benefits of cannabinoids, which we went over pretty thoroughly, but then also how we can help patients optimize safety, efficacy, ease of use, and costs, because this is still not covered by medical insurance nationally, conventionally. There's some case-by-case incidences of workers' comp and a judge mandated order that it be covered, but it's all very hindering. It's a lot of barriers to overcome and hurdles that are in the way of the patient and safe access and evidence-based education. So if we can start with working with medical schools, pharmacy schools, all academic medical institutions to teach at the student level before they graduate and get their degrees, where they can play a role in cannabis medical patient safety and care. They can understand, like, a nurse's role is different because they have incredible bedside manner. They are with the patients for inpatient settings, and they're important to transitions of care. For pharmacists, screening for the risks of drug-drug interactions. For MDs, they're going to be the ones who are going to have to work with everyone else in this multidisciplinary effort to go over where we can mitigate potential drug-drug interactions, where we can implement preemptive protective measures so that the patient does get the optimal safety and efficacy of cannabinoid medication. And then also, I think that it's important that we do medical grand rounds for all institutions. While we're sheltering in place and telemedicine's really made like so many improvements, I think that we also need to take the opportunity where it's not just piecemeal individual subject matter experts doing medical grand rounds. I think it should be a standardized curriculum. If we're going to learn about opioid receptors, we could learn about cannabinoid receptors too. If we're going to be learning about serotonin, dopamine, neurotransmitter signaling pathways, cannabinoids act there. And whether it's endogenous or exogenous, this education is just so overlooked that a lot of times when I'm starting my medical grand rounds, I'm like, all right, type in the chat box, yes or no, or raise your hands. Who's ever heard of the endocannabinoid system before today? And then I'll just have 20, 40, however many specialists just staring at me. And I'm like, okay, we'll begin at the beginning. And once we can get over that hurdle of like the lacking of education, I think we can really help achieve everything that I had mentioned on that aforementioned to-do list.
Excellent, excellent. And I know it's 1 minute past our stopping point. The state of cannabis has graciously offered to extend us by a few minutes because we're not on Marku time anymore, as it were, as the moderator, trying to keep things on time. So we'll go to Jordan, then Sarah. So Jordan, final thoughts for our panel and attendees.
Thank you. I think this has been a wonderful panel, and I've really enjoyed participating, hearing everybody's very brilliant and insightful thoughts. I'm going to springboard from what Monica was just saying, that, and just, remind everybody that, in addition to being a clinician, I run this Association of Cannabis Specialists, and our mission really is a lot of the stuff that Monica was just talking about, educating clinicians at all levels, and really advocating for better access and better research and better education on the federal level. So we work with, obviously, clinicians, we work with companies, and if people want to come to the website, I think it's in the chat box there, I'll put it there again, but if people are interested, this is a resource for them to get information, to participate, and help us kind of advance the cause for patients.
Excellent, thank you. Dr. Sarah Jane Ward, final thoughts for our panel and attendees?
Sure. Yeah. So, my final thought would be, in coming from my world of testing CBD in rats and mice, it's an extremely exciting space. And, I always tell people, if you have a rat or a mouse or a cat that has multiple sclerosis or breast cancer, I can probably give you a good, treatment regimen on how to fix that and understand, the mechanism. So I'm so full of promise with the preclinical, in vitro, in vivo data that I feel very strongly that there is so much clinical application of CBD and other cannabinoids. But I urge anyone who can help in this area that we need clinical studies. I don't know what those clinical studies need to look like, but they are so imperative to understand what doses, what cannabinoids, what routes of administration, and to really nail down the safety. Because many of us, or all of us here, are believers, but we need the evidence in people. So if anybody can help move that forward, please do.
Thank you, Sarah. And, you know, I'm going to jump off that for my sort of final thought for the panel is that, you know, the ignorance in doing science is what creates the excitement of doing science. You know, discovery usually leads to educated ignorance. The old saying, the more you know you don't know. And this educated ignorance is something that should be a source of joy for us. It should be celebrated and enjoyed because all discovery starts with intuition, faith, uncertainty, indeterminism. Without that, we wouldn't have curiosity. And if everything was known about cannabis and the endocannabinoid system, it would truly be a horrible research field because we'd have nothing to do. But as you go forward in this, remember, cannabis is an innocuous substance. It is neither good nor bad inherently. Analyzing and interpreting the data makes it so. I'd like to thank all of our panels for their time and sharing their expertise and thoughts. This has been really, I tried to scribble down as many notes from you guys as possible. This was really fantastic. Thank you so much. Thank you, Susan, for giving us a platform to share our experience, our thoughts, and our perspectives. And this has just been a terrific panel. I can't believe we almost got a full house of different health professionals from different perspectives. Really, really amazing. Thank you all so much.